heart attacks and strokes by 50% and saved $5.8 million. And lo and behold, people agreed to it. And part of the reduction was based on implementing known risk factors, because as you can see down here, if you're reducing blood pressure and lipids and giving aspirin to people in whom it's appropriate, you can potentially reduce events by 75%. And so that was our goal. And we developed these bundles of medication. If you were hypertensive, you got aspirin, a lipid-lowering drug, and an antihypertensive drug. If you had a history of cardiovascular disease, but no hypertension, then you didn't get the thiazide. If you were diabetic, you got the same group. And then if you had a 10-year risk of 7.5% or more, you got aspirin and lipid lowering. And that's based on guidelines from professional societies. So we involved individual persons and patients with coaches. We had a bundle of medications. We organized all the healthcare groups in our region to follow this. And we enrolled in the 9 participating medical groups. We enrolled some 4,000 patients that we've applied this to. Now, along the way, another grant proposal came to deal with racial and ethnic approaches to community health in the African American community, because the African American community had a disparate number of cardiovascular events and a disparate reduction of health care available to them. And so, working with the county, we got a 3rd grant, okay, which was the Healthy Works Prevention Initiative from the Centers for Disease Control. And so, you know, we wound up with this little group with $11 million in total funding, which is not too bad, you know. And this just shows our centers in San Diego. So what have we accomplished? Well, as you can see, our healthcare coaches have had 21,000 encounters with our 4,000 patients, okay? Most of them by telephone, but a good number of them in person, text, and whatnot, interacting with these patients, dealing with why they don't take their medication, why they miss their clinic appointments, why they don't stop smoking, how can they help, what can they do. And so our adherence rates have gone way up. Here's the adherence rate going from 67 to 89% for aspirin, from 60% to 93% for antihypertensive medications, from about 74% to 96% adherence to lipid-lowering therapy with statins. And just one example, patients at goal for blood pressure, we went from 40% in this patient population at high risk to 84%. You know, as process goes, that's really, really good. So we increased adherence across the board to numbers that are way, way higher than are reported in the general medical community. And the effect, if you look at patients who had excessively high LDL levels, it went down from 41 to 35%. People who had hypertension went down from 39% to 20%. Patients who smoked, about a 4 or 5% reduction in smoking. So that we did that not only in men but women. It turns out that women are the forgotten community in terms of cardiovascular risk reduction, and that's something we're very proud of. And you've probably seen this slide before. Brent Fulton, who's a researcher at UC Berkeley, went and analyzed data for acute MI hospitalizations and strokes in San Diego County compared to the rest of the state of California. And the stroke incidence went down both in California and in San Diego, more in San Diego, but the reduction in acute myocardial infarction hospitalizations was substantially greater in San Diego, both at the initiation of our program and when these data were analyzed. You see that's almost a 15% reduction in MIs hospitalized in San Diego relative to the rest of the state of California. These data are impressive. In terms of our REACH goal, we organized the African American community around faith-based groups, UNAMIC, United African American Ministries Action Council, UNAMIC. And we've got all of these faith-based organizations. Okay, you can see 22 of them, African American faith-based organizations in San Diego participating. And they participate in nutrition, they participate in exercise groups, which I haven't loaded here, and they identify each other in their community who are known to have disease and get them into chronic management. So that we'll be anxious to see what the results of this are, but it's working now. It's working because we're in the community, there's a cultural understanding, transparency, partnership. Here's a bunch of us from Be There at one of the African American services that was, I have to say, a hell of a lot more inspiring than my own services, such as they are. So what's next? We're drafting recommendations. I'm coming down the home stretch for all of our professional healthcare institutions to employ in their regular day-to-day activities. So we're drafting recommendations. They go through stakeholder groups, the executive Be There committee, and then because we have champions in Be There from every group, from Sharp, from Scripps, from UCSD, from Kaiser. These champions are going to take back these recommendations. What recommendations? Well, undiagnosed hypertension is data to indicate that within even the best healthcare systems, there's 25 to 30% of people who have high blood pressure, and they're going undetected. We've generated and approved a document on home blood pressure monitoring, which is something we look for. We've just about finished our document on the role of pharmacists, because pharmacists have a really important role in the healthcare team in achieving blood pressure and lipid control. And you can see the rest, pre-diabetes, etc. Here's Grace Kuo, who's a PharmD at UCSD, put together a panel. She contacted every pharmacy and pharmacist in San Diego, administered a baseline assessment to get data, and from that got them together where they agreed upon the best practices, how a pharmacist could best interact. And this document is in its final stages, and it'll be put to the administration of all the healthcare systems in San Diego. So we've feel pretty good about what we've done. We've just barely scratched the surface. We've really only impacted in a major way the African American community and the 4,000 patients. But we think just the halo effect of what we're doing in those groups is spreading rapidly. I know you're doing the same thing. I can't wait to see your statistics and how well you do. But I think it's really a great goal as you know, I've been in medicine for a long time and done a lot of things. And I would say if we can push this to completion and make it sustainable, that it will have been the best thing I ever did in medicine. So thanks for listening.
Thank you, Dr. DeMario. That's excellent work, and some things that we need to really take away and steal from you. And we'd love to do that if you don't mind. We'll have time for questions after Dr. Baumer's presentation. And now I want to have the distinct pleasure of you all know Dr. Baumer, of course, he's our new co-director. But I wanted to just spend a few seconds to just acknowledge that we appreciate his participation. He is at UC Davis and is the director of the Cardiology Fellowship Program there. He's helped train over 200 practicing cardiologists and has published over 250 scientific articles and is known both locally, statewide, nationally, and internationally. And we're very privileged to have Dr. Baumer, who is going to share some of his thoughts around our work on cardiovascular risk reduction. And we're extremely excited that he will bring his co-directorship and energy to Right Care in Sacramento. So thank you, Dr. Baumer.
Thank you very much. Normally, I'm just the warm-up talk for Tony, so I actually prepared this talk when we discussed earlier as the introduction for Tony. So I think just blank out what Tony saw, and we'll go through this, and then roll back in your memory what Tony said to follow that sequence. So what I have up here is perhaps an idyllic shot of Sacramento that you see here. It is highlighted by high areas of healthcare, where we have a lot of excellent hospitals in California, in Sacramento. We have the population. We're down here at the boots level to an exercise path, and we have water sports, we have exercise. So we should be the ultimate healthy community that we're looking at for it. So that's what our idyllic goal is for Sacramento. Whoops. So these got started at the end, so I'm going to hang on. We're starting at the back of the talk, so if we could just click on, without going through every one, is there a way to get to the
one at a time?
So as I said, we're presenting this backwards, but I didn't intend to start the whole thing backwards. So
Thank you for that title, because that's what it's all about. Applying everything we know to get to zero. Preventable, premature cardiovascular events.
yeah, that okay, all right, okay.
Thanks.
All right, so anyways, idyllic site here. What we're going to talk a little bit about is, for Sacramento, healthcare from the top level down to the bottom level. We're going to talk about healthcare in our hospitals and our communities that are in Sacramento. But then we're going to go down to boots on the ground. How are we doing for the individuals at the boots on the ground? So we're going to look at high-end care, and then we're going to look at the very important thing that, as Tony showed, the bottom of the pyramid, how to prevent disease, how do we prevent getting into these hospitals that we're looking at today. So we're going to look a little bit from the high end, talking about California and Sacramento cardiovascular mortality, our hospital cardiovascular mortality, our PCI mortality. We'll talk a little bit, Tony already covered it, about global risk factors and how good a job we're doing in Sacramento with our various aspects of demographics in producing or controlling risk factors to lead to that ultimate goal. And our ultimate goal is getting to 0 preventable cardiovascular deaths. And that's why we're here, or sitting here today. So starting at the top, so there's a top side view coming down. Here are the 9 hospitals in Sacramento County that are listed here. See, we start at the river, follow the river as we go along there. And those are the hospitals that we're going to analyze right now. How good a job are they doing? So here's the most recent data that we have for the 9 hospitals shown on the left in Sacramento County here. Now, to organize you to this, I believe it's a little bit fuzzy on your side, but the hospitals are listed over here on the left. And then what we have listed here is various medical problems: acute myocardial infarction, total strokes, the different types of cardiovascular strokes, and then over here we have heart failure. Now, in this matrix that you see from the back of the room, you can see there are white squares and there are gray squares. The white squares say that this hospital, for this performance metric, is within the standard. That is, it is average within the state of California. I have the state numbers up here for that. You can see are, for the first item, acute myocardial infarction. You can see the state mortality for that is 5.9%. You can see that all of the hospitals in Sacramento are within that number of 5.9%, and there is one gray box here. The gray boxes on this entire matrix are outliers. They're outliers for what? In this situation in Sacramento, they're outliers for better outcomes than the rest of the state of California. So that you can see here that all of our hospitals in Sacramento are within average for that, with the exception of UC Davis, which is better than average for mortality at 2.4%, about half the acute MI risk the rest of the state is for that. As we go through the line here, again, we can see for total strokes, there are 2 gray bars here, meaning 2 of our hospitals are above average for it, the rest are average. We look at each individual type of stroke, 2 again are better for that. If we get over here to heart failure, what we can see is 1, 2, 3, 4 of the hospitals out of 9 in California are statistically better than the average in the state of California. So if you look here, you can see all hospitals for performance metrics for mortality in these hospitalized cases are as good or better than the rest of the state of California for mortality. And this is statistically significant. Our most recent data, it only shows 9 months because that's when we changed from ICD-9 codes to 10. And we haven't come through and added the ICD-10 codes for that. So at a hospital level for mortality, we're as good or better than the state of California. And in many of these hospitals that you can see here, we are significantly better than the rest of California for lower mortality for these diseases.
If the person makes it to the hospital, right?
If for patients, as I said, we're starting at the top end, which is the peaks of the hospitals I showed on that picture, correct? So these are hospitalized patients. Now, in the hospital, many of our acute MI patients or coronary patients get an intervention. How are we doing with that? I'm going to show you again data for PCI mortality for each of the hospitals in California for 2 groups. One is going to be with acute myocardial infarction, followed by without acute coronary syndrome for that. So the first hospital is shown here. It's Kaiser South. You can see they just started their PCI program here 2 years ago. And what we've got listed on this scale is every hospital in the state of California. So if you look here, each bar represents a separate hospital of the 140 that we looked at in California and their PCI outcomes. The average mortality is this line, this brown line through the middle. And if a hospital lies on this side of the average, it's better than average. If it's on this side, it's worse than average. So for Kaiser South, we see here is average. It's a little less than optimal than average, with a little higher mortality for individuals who have PCI with acute myocardial infarction or with acute coronary syndrome for that. Looking at elective cases at Kaiser South, what we see here, the line is over here. Again, there was a problem in 2014 with a higher than expected elective mortality for it. It got better right here. And as you know, Kaiser South has recently joined our offsite PCI program, and we're working with them to keep this low at this point in time for that. And you can see that our concern there is to, in fact, shift this over towards the middle of the pack as far as looking at that.
Bill, I'm sorry to interrupt you, but can you just go back to that slide so I really understand it? So if the hospital's on the far right?
Scale is the actual mortality shown here. Shown here on the bars, each one of these bars on the horizontal scale is a different hospital in the state of California, and every PCI hospital in California is shown on this slide. And the middle of the bar is the mortality at that individual hospital. The width of the bar is the confidence intervals for it, and therefore if a hospital is doing a lot of numbers, it's going to have a relatively narrow width, and if it's doing a few number, then it's going to be a wider confidence interval. And if the confidence interval misses the line here, then it's statistically significantly higher event rate. In this case, if it were on this side, it could be statistically significantly better outcomes than the rest of the state. And so that's with ACS. This is the next hospital is Mercy General here in town. And what you see for Mercy General is their average mortality here. The state is in the solid brown line, and Mercy General is shown here over the last 20 years, basically, or 15 years for that. And what you see, they're pretty close to average here with acute coronary syndrome, and that is they're just a little bit higher than average for the state for their mortality PCI in patients with acute coronary syndrome. These are the more elective without ACS at Mercy General that you see here, and they're a little better than average in this situation, but very close to average, but better than average for Mercy General without acute coronary syndrome in that case. The next hospital here is Mercy San Juan. Mercy San Juan with acute coronary syndrome sits right here. That's the dot. You can see a little worse than average, but pretty close to average for overall mortality with acute coronary syndrome. Here is Mercy San Juan without acute coronary syndrome. A little bit higher over here, but still not statistically different from the rest of the pack at this point in time for that. Our next hospital is Sutter General Hospital. Sutter General, again, if we follow it, here is the average state, and they're up and down compared to the rest of the state. This is the last year that we looked at here. And for with acute coronary syndrome, you can see they're close to the center of the pack for Sutter General with acute coronary syndrome. And if we look at elective cases at Sutter General, PCI cases, you can see they're better than average with a statistically significant lower mortality shown here in this dot with no overlap with the mean line for it for Sutter General Hospital without ACS situation. If we look at now UC Davis Med Center, here it is over the last 17 years plotted here, up and down compared to the mean for California. You can see the ranking for the last 2 years that we're looking at for all of these hospitals is with ACS shown over here, statistically better than the rest of the hospitals in California for mortality in individuals with acute coronary syndrome at UC Davis. And if we look at the elective cases at UC Davis, again, the dot lies on this side of the middle, or the median shown here, with better than average performance in the elective ACS, or the elective patients for PCI in the state of California. So what do we have for the 9 hospitals that we've just looked at in California? Average or better than average performance for PCIs. We have better or average performance for acute MIs and stroke therapy mortality for, as Hattie pointed out, hospitalized patients. Every one of these events that we're tracking here is once they get to the hospital, what happens to those individuals. So hospital care in Sacramento appears to be reasonably good compared to the rest of the state of California. Now, as you know, in Sacramento, we now have 3 hospitals that we've opened just recently that have PCI programs for STEMIs and acute MIs that do not have on-site cardiac surgery. Now, it was always a question, if you open a program with a hospital without surgery, is that going to be a problem? We had a pilot program in California for 5 years that we ran, and we looked at hospitals without cardiac surgery and do they perform as well as hospitals with cardiac surgery for the patients who are requiring interventions for coronary artery disease. So the pilot program was shown here. We've now extended it from 6 in the pilot program to now we have 18 hospitals in California that have applied or been certified for off-site PCI programs in the state of California, now representing about 15% of California hospitals are doing and taking care of these coronary patients without having cardiac surgery in the hospital for them. So how are we doing with those programs? Well, in our pilot program that we did, here is the state of California mortality risk adjusted. What you see is for all comers coming in for PCI in the state of California, the average is 2.56 mortality. In the off-site hospitals, it's a little bit better, 1.98. So off-site hospitals without surgery do as well. And the reason I bring it up is we now have 3 off-site programs here in the Sacramento area that we've introduced in the last 1 to 5 years in California. We want to make sure those programs do as well as the standard hospitals for it. They appear to do it. In fact, when we looked at the individuals, the off-site hospitals, known as campus, did as well or were better than the state average, whereas when we looked at the other 120 hospitals in the state which have surgery on site, we found some were better, but we found 10 and now 11 worse outliers, meaning that if there's a problem in hospital PCI care in the state of California, it's happening right now at hospitals that have surgical programs on site. I'm happy to say for Sacramento, none of those worst outliers are in the Sacramento region. So again, Sacramento performance on admission diagnosis for a hospital for those cardiovascular events as good or better than the rest of the state, and no worse outliers here. We're dealing with the worst outliers, but they're not in the Sacramento area. We're working with them closely to improve their cardiovascular event mortality. In addition to looking at mortality, we do look at other parameters, whether they're on aspirin, they're on statins, the therapy they're getting, etc. And the off-site hospitals are doing a very good job for that. In fact, if we look at things like aspirin at the off-site hospitals, 98.7% that we're seeing. If we look at antiplatelet therapy, 93%, statins, 97%. Hospitals in the pilot program and in Sacramento are doing a pretty good job, and they're above 95% discharge on these standard or these needed medicines that we're following for them. So again, an excellent job for that. We're now monitoring the entire state, so every hospital in the state we monitor. that is enrolled in the CAP PCI program of the NCDR that looks at, and we're monitoring 240 variables that we use for